Hello, everyone. Today, I want to guide you through a practical cardiac ultrasound session, focusing on left ventricular systolic dysfunction and showing how what we see on echo is strongly connected with electrophysiology and, in some cases, pacing therapy. I will approach this as we are working together on the ultrasound system. Before starting with imaging, I always like to recall a few key concepts about how the heart works. Heart is a pump, but is also an electrical system. So every contraction is generated by an electrical impulse that starts in the sinoatrial node, spreads through the atria, passes the atrioventricular node, and then activates the ventricles through the His-Purkinje system. What we see on the ECG, like the P wave, the QRS complex, and the T wave, is directly linked to what the myocardium is doing mechanically. During systole, the ventricle contracts and ejects blood, while during diastole, it fills. If we think in engineering terms, we are always looking at the relationship between pressure, volume, and the time. If the electrical activation is not correct, the mechanical response will not be efficient. And this is exactly what we try to identify with imaging. Now, moving to echocardiography, the first step is always image acquisition. For cardiac application, we use a phased array probe because it allows us to work through small acoustic windows between the ribs while maintaining good temporal resolution. When I position the probe, for example, in the apical four-chamber view, I am aligning the ultrasound beam with the long axis of the left ventricle. This is important because many of the parameters we measure, especially strain, depend on this alignment. From a practical point of view, there are a few things I always check during acquisition: correct probe position and stable window, good endocardial border definition, adequate frame rate for motion analysis. If the image quality is not good, all the advanced measurements will be unreliable, especially speckle tracking. Once we have a good image, we move to the evaluation of the systolic function. The most common parameter is the ejection fraction, which gives a global estimate of how much blood is pumped out during systole. However, as we know, ejection fraction has limitations and may not detect early dysfunction. This is why we use strain imaging. With the speckle tracking, we follow natural acoustic markers within the myocardium across the cardiac cycle. This allows us to measure myocardial deformation. In particular, global longitudinal strain reflects how much the myocardial fibers shorten during systole. In normal conditions, values are around minus 18 to minus 20%. When these values become less negative, it means that the contractive function is reduced, even if the ejection fraction is still preserved. If we consider a pathological condition like dilated cardiomyopathy, the ventricle becomes enlarged and this contractility decreases. On echo, we can see a reduction in ejection fraction, but also a clear reduction in strain values across multiple segments. This gives us not only a diagnostic indication, but also a prognostic information since these parameters are linked to patient outcomes. At this point, it's important to integrate what we see on echo with what we see on the ECG. For example, if there is a conduction delay, such as a bundle branch block, the QRS complex becomes wider, typically above 120 milliseconds. This means that the electrical activation of the ventricles is not synchronous. From a mechanical point of view, this results in dyssynchrony. Different segments of the left ventricle contract at different times, reducing the efficiency of the pump. On echo, this can be observed as a delayed contraction of specific walls, and strain imaging can make this even more evident. This is where imaging becomes directly relevant for therapy. In patients with heart failure, reduced systolic function and electrical dyssynchrony, cardiac resynchronization therapy can be considered. The idea is to restore a coordinated contraction by pacing both ventricles. In this context, echocardiography is essential not only to identify suitable patient, but also to support follow-up and evaluate the response to therapy. From an electrophysiology perspective, we also have to consider arrhythmias. This can originate from abnormal impulse generation, for example, in ectopic foci, or from conduction abnormalities. Conditions like tachycardia, bradycardia, or atrial fibrillation can significantly affect cardiac performance. For instance, if the heart rate is too high, diastolic filling is reduced, and this directly impacts stroke volume. If the rhythm is irregular, as in atrial fibrillation, the contribution of atrial contraction is lost, and ventricular filling becomes less efficient. Echocardiography allows us to evaluate the consequences of these electrical disorders on cardiac function. At the same time, the ECG provides information about timing and conduction, so combining these two tools is fundamental. From my perspective as a biomedical engineer, my role is to manage this interface between technology and clinical application. I focus on optimizing image acquisition, understanding the underlying signal processing, and supporting the clinician in interpreting both standard and advanced parameters. At the same time, I am particularly interested in how imaging findings can guide therapeutic decisions, especially when dealing with devices such as pacemakers or resynchronization systems. So in a real clinical workflow, what we do is not just acquire images. We integrate electrical information, mechanical function, and clinical context to support decision making. And this integrated approach is, in my opinion, one of the most interesting aspects of working in cardiac imaging today. Thank you for watching.